Hyperemesis gravidarum. Hyperemesis gravidarum is a severe type of vomiting of pregnancy which has got deleterious effect on the health of the mother or incapacitates her from her day-to-day activities. The adverse effects are dehydration, metabolic acidosis, alkalosis, electrolyte imbalance, and weight loss. Risk factors of hyperemesis gravidarum includes first trimester, first pregnancy, young age, low body mass, history of motion sickness or migraine, family history which involves mother or sisters also suffering from the same manifestation, and unplanned pregnancies. Theories of hyperemesis gravidarum. The first one is the hormonal theory. It states that there is excess of chorionic gonadotrophin, high serum level of estrogen, and excess progesterone. The second one is the psychogenic theory. It aggravates the nausea once it begins, but neurogenic element sometimes plays a role. Conversion disorders, somatization, excess perception of sensations by mothers are other theories. Diagnosis. Pregnancy is to be confirmed first. Ultrasonography is useful not only to confirm pregnancy but also to exclude obstetric, gynecological, surgical, and medical causes. Complications of hyperemesis gravidarum. The first one is neurological, which includes Wernicke's encephalopathy, beriberi, Pontine myelinolysis, peripheral neuritis, and Korsakoff's psychosis. Other complications include stress ulcer in the stomach, esophageal tear, jaundice, hepatic failure and renal failure, convulsions, coma, and hypoprothrombinaemia. Effect of hyperemesis gravidarum on the fetus. The fetus usually remains unaffected once the problem is resolved. Fetal risks may be due to low birth weight and preterm birth. Prevention measures. Drink fluids in between meals and not after the meal. Not to lie down immediately after meals. Avoid food that cause gastric irritation. And avoid high-fat food and odors that trigger nausea and vomiting. Management of hyperemesis gravidarum. The principles include maintenance of hydration, to control vomiting, to correct the fluid and electrolyte imbalance, to correct metabolic disturbances, and care of pregnancy. Under management, the first one is hospitalization. Whenever a patient is diagnosed as a case of hyperemesis gravidarum, she is admitted with the same diet and drugs. The second one is fluids. Oral feeding is withheld for at least 24 hours after the cessation of vomiting. During this period, fluid is given through intravenous drip method. The amount of fluid to be infused in 24 hours is calculated as the total amount of fluid approximates 3 liters, of which half is 5% dextrose and half is Ringer's solution. Extra amount of crystalloids equals to the amount of vomitus and urine in 24 hours is to be added. Serum electrolyte should be corrected if there is any abnormality. The third part is drugs, which include antiemetic drugs. For example, promethazine 25 mg or prochlorperazine 5 mg may be administered twice or thrice daily. Doxylamine, which is an antihistamine, can be administered for nausea and vomiting. Metoclopramide stimulates gastric acid and intestinal motility without stimulating the secretions. Hydrocortisone 100 mg is given intravenous IV for hypotension or intractable vomiting, and nutritional supplementation with vitamin B, vitamin B6, vitamin C, and vitamin B12 are given. Other management techniques include nursing care, wherein sympathetic but firm handling of the patient is essential. Social and psychological support should be extended. Few points to remember. Hyperemesis progress chart is helpful to assess the progress of the patient while in the hospital. Daily record of pulse, temperature, and blood pressure at least twice should be done daily. Clinical features of improvement is when there is subsidence of vomiting, feeling of hunger, better look, normal urine output, normal pulse and blood pressure, disappearance of acetone from the breath and urine, normalization of blood biochemistry. Diet plan. Before IV is omitted, foods are given orally. At first, dry carbohydrate foods, for example biscuits, bread, toast, are given. Small but frequent feeds are recommended. Gradually, full diet is restored.